Welcome back to McLaren Port Huron's Today's Health Program. I'm speaking today with Dr. Karadimas about arthritis of the knee. Dr. Karadimas, how do you diagnose the cause of knee pain?
Like anything else, the main diagnosis is going to come from a physical evaluation. So a patient comes in the office and you listen to their story, examine their knee. Of course, a big part of diagnosis for osteoarthritis is going to be X-ray radiographs. We have one here. In fact, this is an X-ray of a normal-looking knee. On X-ray, basically, you're going to see the bones. You're not going to see the cartilage. So you have the femur on top, the tibia on the bottom. And if you see right here, there is actually a little space between there. And that is not air. That's actually cartilage. That's the cartilage cushion that will wear with osteoarthritis. Now, we have a arthritic knee to show, and you can see in this knee much different. You have these large bone spurs. You have still some space on the outside, but on the inside you've completely lost that cartilage space. You have spurs all over the place. The knee's gone a little crooked, so this is a very arthritic appearing knee.
Once a diagnosis of arthritis is made, what are the available treatment options?
So we have the non-surgical treatment options, and those are going to include some type of oral anti-inflammatory, the Motrin type medications. And from there, we do a little bit of physical therapy, but it's not done that much anymore. It doesn't really have any significant improvement with osteoarthritis. Injectables do work well. We have corticosteroids, modern day cortisone that we can inject to the knee, which is like a super Motrin. We have these lubricating injections that we can put into the knee. It's like a thick gel lubricant. Think of it as like a WD-40. You got a worn out ball bearing. We're putting some WD-40 in there so it can kind of move a little bit better. That's probably the most common thing to see, steroid injections and these lubricating injections. In the forefront, though, we do have some new things coming out. We're playing around with embryonic stem cells, bone marrow injections, bone marrow stem cell injections. That's all being looked at. But for now, it's going to be your basic anti-inflammatories and steroid or lubricating injections, with some things in the future I hope to come.
So with the medications and the injections, how long would you typically recommend that a patient do this before considering surgical options? And
that's always a tough question, Michelle. It's going to be, for me, it's always a matter of how much improvement are you really getting, so some people can get a lot of improvement, and in that case, why not kind of let things go for a while? But if you're doing these things and getting a very small amount of improvement and it's still really impeding your life, I think at that point, we consider moving to the next step.
Dr. Karadimas, this is great information. We need to take another break. We'll continue in a moment.